Okay, we're back. Hey, it's Dmitriy again, and today we're going to be covering the cardiovascular section of First Aid for the USMLE Step 1 textbook, the 2025 edition. However, the PDF that I have in front of me is the 2017 edition. So there's going to be some, dissimilarities essentially. There's going to be some differences between the two. Overall, the same kind of content, but there are some differences here and there, and especially how it's organized sometimes. So you can follow along if you have a 2017 edition or a 2025 edition, or for that matter, any of the editions in between. Again, this is a Step 1 textbook. We start off with the quotes for the cardiovascular section. Cardiovascular. As for me, except for an occasional heart attack, I feel as young as I ever did. Robert Benchley. Hearts will never be practical until they are made unbreakable. The Wizard of Oz. Okay. As the arteries grow hard, the heart grows soft. H.L. Mencken. Okay. Nobody has ever measured, not even poets, how much the heart can hold. Zelda Fitzgerald. That's a little bit more poetic, I think. The art of medicine has its roots in the heart. Paracelsus. It is not the size of the man, but the size of the heart that matters. Evander Holyfield. Okay, with that out of the way, here's a little snippet right here in the front. The cardiovascular system is one of the highest yield areas of the boards. Sorry. The cardiovascular system is one of the highest yield areas for the boards, and for some students, maybe the most challenging. Focusing on undertaking the mechanisms instead of memorizing the details can make a big difference. Pathophysiology of atherosclerosis and heart failure, mechanisms of action of drugs, particularly their interplay with cardiac physiology, and their adverse effects. EKGs of heart blocks, the cardiac cycle, and Starling curve are some of the more high-yield topics. Differentiating between systolic and diastolic dysfunction is also very important. Heart murmurs and maneuvers that affect these murmurs also have been high yield and may be asked in a multimedia format. So what they're saying is maybe they might give you a situation where they, here, listen to this video for the murmur, and then you have to answer a question, that kind of thing. So we'll continue with this. We're going to go immediately into the cardiovascular section, the embryology section. So it's embryology, then anatomy, then physiology, then pathology, then pharmacology. Very similar setup to many of the other chapters. And this chapter, I believe, is going to be about 45 pages long. Now the PDF is a little bit shorter than that. But for me, what I'm seeing here is that I think I end on page 238, and I'm starting off at 283, something like that. 328, I believe. Let me just make sure. Yeah, I end at 328, we start at 283. So it's about 45-ish pages. So let's start off on embryology. Heart morphogenesis. First functional organ in vertebrate embryos beat spontaneously by week 4 of development. Cardiac looping. Primary heart tube loops to establish left-right. Polarity. Begins in week 4 of development. So again, it's going to start the sort of left-right polarity and begins the 4th week of development. Defect in left-right dynein involved in left-right asymmetry can lead to dextrocardia as seen in Cardiac syndrome. So Cardiac syndrome, you have a dynein deficiency, that's dynein, and if you have an issue with that, you might have dextrocardia, which is to say that the heart is actually going to be on the right side as opposed to the left side where it normally should be. Septation of the chambers. Talking about atria first off. Now, your book has a little bit different setup where they talk about the different regions like the truncus arteriosus, pulpus cordis, etc. They might mention that later on, or they might not consider it to be as important as it used to be. I'll have to see how it goes. But let me go into what they're talking about right now, which is atria. And you can see that section right here with the diagram and everything like that. Septation of the chambers, atria. Number 1, septum primum grows towards the endocardial cushions, narrowing ostium primum. 2. Ostium secundum forms in septum primum due to cell death. Ostium primum regresses. 3. Septum secundum develops on the right. side of the septum secundum develops on the right side of the septum primum, as ostium secundum maintains right to left shunt. 4. Septum secundum expands and covers most of the ostium secundum. The residual foramen is the foraminal valley. 5. Remaining portion of the septum primum forms the one-way valve of the foraminal valley. 6. Septum primum closes against the septum secundum, sealing the foraminal valley soon after birth because of the increase in left atrial pressure and the decrease in right atrial pressure. 7. Septum secundum and septum primum fuse during infancy/early childhood, forming the atrial septum. Now, the last two are not shown, but they are still stated in that description. Patent foraminal valley. Caused by failure of the septum primum and septum secundum to fuse after birth. Most are left untreated, can lead to paradoxical emboli, venous thromboemboli that enter the systemic arterial circulation, similar to those resulting from an ASD. Okay, and you can see that diagram there. I'm going to go zoom in a little bit, if that's better. Let me see that. Yeah, that looks a little bit better. So I'll keep it like that for now. And you can kind of just see how the transition is between those different. You can look it up online as well. But that transition from just the septum primum, eventually you're going to get a foramen secundum, you're going to have, then eventually the septum secundum, and so forth, until you eventually have a working wall between the two sides, which is going to happen after birth when the change in pressures occur, and it's finally sealed off. It's actually very interesting to think about the fact that before birth, because of the fact that you're not breathing air, the heart has to work quite differently in many ways, and then it has to quickly change in its function once you are breathing air, Anyway, heart morphogenesis continued. Ventricles. 1, and you can look at the diagram as well for this. 1. Muscular interventricular septum forms. Opening is called the interventricular foramen. 2. Aorticopulmonary septum rotates and fuses with muscular ventricular septum to form the membranous interventricular septum, closing the interventricular foramen. 3. Growth of the endocardial cushions separates atria from ventricles and contributes to both the atrial septation and the membranous portion of the interventricular septum. And so you can see the diagrams for those three respectively. Ventricular septal defect, or VSD, most common congenital cardiac anomaly, usually occurs in membranous septum. So the membranous part is usually where it's going to happen. The atrioventricular septal defect, AVSD, which your book doesn't have, but I'll read it out. So AVSD, also known as the endocardial cushion or AV canal defect, acyanotic congenital heart defect with single common AV valve plus either ASD alone, partial AVSD, or both ASD and VSD, complete AVSD, associated with Down syndrome, maternal diabetes, and obesity. Now the outflow tract formation. Neural crest and endocardial cell migrations. I'll read my book. Neural cell crest migrations leading to truncal and bulbar ridges that spiral and fuse to form aorticopulmonary septum, leading to ascending aorta and pulmonary trunk. Conotruncal abnormalities associated with failure of neural crest cells to migrate. You have transposition of the great arteries, TGA, tetralogy of Fallot, and persistent truncus arteriosus. Now, tetralogy of Fallot, that is itself, the name gives it away. That's 4 different things going on at the same time, including a VSD. Valve development. Aortic/pulmonary, derived from the endocardial cushions of outflow tract. Mitral/tricuspid, derived from fused endocardial cushions of the AV canal. Valvular anomalies may be stenotic, regurgitant, or atretic, that is to say, like tricuspid atresia, or displaced, for example, Epstein anomaly. Now we're going to be talking about that thing we were talking about before, about the different structures, the embryonic structure. Heart embryology, embryonic structure. So the embryonic structure, which gives rise to those respective things. And this feels like very much like a memory kind of thing on some level, so you might want to just kind of quiz yourself on that if you want to at some point. embryonic structure gives rise to? Okay, the right common cardinal vein and right anterior cardinal vein give rise to the superior vena cava. The posterior cardinal, subcardinal, and supracardinal veins give rise to the inferior vena cava. The right horn of the sinus venosus gives rise to the smooth part of the right atrium, the sinus venarum. The left horn of sinus venosus gives rise to the coronary sinus. The primitive pulmonary vein gives rise to the smooth part of the left atrium. The primitive atrium gives rise to the trabeculated part of the left and right atria. Endocardial cushion gives rise to the atrial septum, membranous intraventricular septum, and the AV and semilunar valves. Primitive ventricle gives rise to the trabeculated part of the left and right ventricles. Bulbus cordis gives rise to the smooth parts, outflow tract of the left and right ventricles. And then finally, the truncus arteriosus gives rise to the ascending aorta and the pulmonary trunk. Okay, what about fetal postnatal derivatives? Talking about ductus arteriosus and that kind of thing. Let's see if we can find that here. Right here. Oh, here's a graph for fetal circulation. We'll get into that in a bit. So fetal postnatal derivatives. So we have the fetal structure, postnatal derivative, and the notes. So we have ductus arteriosus that gives rise to the ligamentum arteriosum. And this is near the left recurrent laryngeal nerve. Okay. Ductus venosus gives rise to the ligamentum venosum. Easy enough. Okay. Ductus arteriosus, ligamentum arteriosum. Ductus venosus, ligamentum venosum. Okay. Foramen ovale gives rise to the fossa ovalis. The allantois, I would assume it's allantois, maybe allantois, gives rise to the uricus. Allantois going to the uricus gives rise to the median umbilical ligament. Note, the uricus is part of the allantois between the bladder and the umbilicus. Okay. So again, allantois to uricus becomes a median umbilical ligament. The umbilical arteries give rise to the medial umbilical ligaments. And the umbilical vein give rise to ligamentum teres hepatis, the round ligament of the liver. And a note on this is contained in the falciform ligament. So within the falciform ligament, there is a round ligament of the liver, and that is called ligamentum teres hepatis. And that round ligament comes from the umbilical vein. Now we're going to talk about the fetal circulation. Fetal circulation. 3 important shunts. 1. Umbilical vein, ductus venosus to IVC. Umbilical vein goes to ductus venosus, goes to the inferior vena cava, bypassing hepatic circulation. 2. Most of the highly oxygenated blood from the inferior vena cava goes to the foramen ovale, which goes to the left atria. 3. Deoxygenated blood from the superior vena cava goes to the right atria, which goes to the right ventricle, which goes to the main pulmonary artery, which then goes to the ductus arteriosus, which then goes to the descending aorta. Shunt is due to the increase in fetal pulmonary artery resistance. Okay. At birth, infant takes a breath, and this decreases the resistance in pulmonary vasculature, leading to an increase in left atrial pressure versus the right atria pressure. That leads to a foramen ovale closure, now called the fossa ovalis. This an increase in oxygen from respiration and a decrease in prostaglandins from placental separation leads to the closure of the ductus arteriosus. NSAIDs, for example, indomethacin, ibuprofen, or acetaminophen, help close the ductus arteriosus, or PDA. So ligamentum arteriosum, leading to ligamentum arteriosum, which is a remnant of the ductus arteriosus. So endomethacin ends the PDA. Sure. Prostaglandins like PGE1 and PGE2 keep PDA open. So the prostaglandins help prolong it, keep it around longer. And indomethacin does the opposite. It helps close it early on, or helps close it basically, and closes the PDA. So here's a little structure you could see And unfortunately, your book only has I think the original version of it. But you can also look online to see versions of this where there's a transition from well, I think this is actually, let me see. I think this looks like it's prior to, let me see. Yeah, I think this is the one trying to show, yeah, okay, fair enough, yeah. I'm just looking at the heart, so I guess it's better to look at the placenta. This is showing what it looks like prior to birth, right, in terms of the arterial system, the cardiovascular system. And you could just look online, perhaps, if you want to see a diagram where it's showing a comparison between, prenatal versus postnatal. Now we're going to go to the anatomy, I think. Yep, okay. Okay, cardiovascular anatomy. Heart anatomy. The left atrium, also, by the way, for reference, when they say LA, that's left atrium. When they say RA, that's right atrium. When they say LV, that's left ventricle. When they say RV, that's right ventricle. When they say RCA, that's the right coronary artery, et cetera, right? That kind of thing. Just be aware of that. They like to just use the abbreviations, unfortunately, without necessarily. When it says SVC, superior vena cava. When they say IVC, inferior vena cava, okay? So left atria is the most posterior part of the heart. Left atria enlargement, for example, in mitral stenosis, can lead to compression of esophagus, leading to dysphagia, compression of the left recurrent laryngeal nerve, causing a branch of the vagus nerve, which is a branch of the vagus nerve, and that leads to hoarseness, also called Ortner syndrome. Right ventricle is the most anterior part of the heart and is the most commonly injured in trauma. Left ventricle is about 2/3, and right ventricle is about 1/3 of the inferior diaphragmatic cardiac surface. Pericardium, I think it might be in a different area. Let me check. I have the same diagram here. This is the same diagram right here. So maybe they really kind of changed this section of it, perhaps. Maybe they did a lot of renovation, perhaps. Pericardium. It consists of... This has to be a different location, doesn't it? Come on. I think I've been talking about pericardium somewhere, right? I guess not. Maybe not. Okay. Pericardium consists of 3 layers, from outer to inner. Fibrous pericardium, parietal pericardium, epicardium, which is the visceral pericardium. Oh, it's right there, I guess. Showing it from that area. If you look at the heart diagram for A, it's right here. I'll go back up just so you can see. What can you see? I want to make sure that I'm not covering too much. Okay, good. Okay, so the 3 layers are those. Okay. Fibrous, parietal, and then the epicardium, which is called visceral pericardium. So fibrous, parietal, visceral. The pericardial space lies between the parietal pericardium and the epicardium. The pericardium is innervated by the phrenic nerve. Pericarditis can cause referred pain to the neck, arms, or other part, or both shoulders, often the left shoulder though. And bear that in mind when somebody has something like a heart attack, for example. There's a little diagram that shows the fibrous pericardium, then the parietal pericardium, then there's this pericardial space in between the two, and then you have an epicardium, also called the visceral pericardium, and then you can see the coronary vessels that are just below it, and then you see all the myocardium that's present. It's a pretty thick layer of muscle, and then below that there's the endocardium, which is what the the blood is actually touching. When you have the heart pumping the blood, it's touching the endocardium, which is the internal layer. Coronary blood supply. Let's see if we can talk about that now. It's right here, I think. Coronary blood supply. LAD and its branches, which is the left anterior descending, by the way, LAD. So the left anterior descending and its branches supply about 2/3 of the interventricular septum, anterolateral papillary muscle, and anterior surface of the left ventricle, most commonly occluded. Posterior descending artery, or PDA, supplies the posterior third of the interventricular septum, the posterior two-thirds of the ventricular walls, and the posteromedial papillary muscle, and the SA and AV nodes, as determined by dominance. Infarct may cause nodal dysfunction, bradycardia or heart block. Right acute marginal artery supplies the right ventricle. Dominance. Right dominant circulation, most common. PDA arises from RCA. Left dominant circulation, PDA arises from the left circumflex artery, which is about 5 to 10% of patients. Codominant circulation, PDA arises from both the left circumflex and the right coronary artery. This is true about 10 to 20% of patients. Coronary blood flow to the left ventricle and interventricular septum peaks in early diastole. Coronary sinus runs in the left AV groove and drains into the right atrium. And so you can see a diagram of the heart right there. And it gives you some hints as to what it looks like. I would look at other perspectives on the heart as well, because just so you can get an understanding of what the back of the posterior part of the heart, what the diaphragmatic part of the heart looks like, that kind of thing. Now we're going to transition very quickly over into physiology. So physiology section right here. Cardiac output variables. So cardiac output variables, okay. So stroke volume affected by contractility, afterload, and preload. Stroke volume increases with increased contractility, for example, in anxiety and exercise, increase in preload, for example, during pregnancy, early pregnancy, I should say, or a decrease in afterload. SV cap. Stroke volume, which is a little mnemonic, I guess. Stroke volume, and the cap is the contractility, afterload, preload. Doesn't tell you which one needs to be increased or decreased, but just remember that contractility and preload will increase it, and afterload will lower it if there's a lot of afterload. So you want to decrease your afterload, you want to increase your contractility and preload if you want to have a higher stroke volume. So stroke work, SW, is work done by ventricle to eject stroke volume. So stroke work is analogous to stroke volume times mean arterial pressure. I hope I'm saying that correctly. Equivalent to sign. I'm trying to think what the correct term for that is. Yeah, I'm trying to think what it's called. Sorry. There's a word for that, where it's like it looks like an infinity sign, but it's not actually an infinity sign. It's open. So it's like stroke work is analogous. I guess it'd be. I want to say analogous to stroke volume times mean arterial pressure. So let me just look that up. SW to SV MAP. Stroke work. Oh, I'm looking up a line that says it's equal to. So stroke work is equal to stroke volume times MAP. So basically, it might as well be equal. So anyway, a failing heart has a decrease in stroke volume, systolic and or diastolic dysfunction. Okay, contractility. Contractility and stroke volume increase with catecholamine stimulation by the beta-1 receptor, and under that it's going to be activated protein kinase A, leading to phospholambin phosphorylation, and leading to active calcium ATPase, which leads to increased calcium storage in sarcoplasmic reticulum. Also, for catecholamine stimulation via beta-1 receptor includes activated protein kinase A, leading to calcium channel phosphorylation, which leads to increased calcium entry. This leads to increased calcium-induced calcium release. Okay. Also, contractility increases and stroke volume increases with increased intracellular calcium, of course. Digoxin, which blocks sodium-potassium pump, which leads to increased intracellular sodium and therefore a decrease in the sodium-potassium exchanger, which then again increases intracellular calcium. So basically, even though they're saying that these are three different things, kind of, within the context of contractility, or I guess maybe you could say four different things, arguably, they all sort of lead to the same thing, which is calcium is going to help you increase contractility and therefore also stroke volume. So contractility and stroke volume decrease with the following: beta blockade, which decreases cyclic AMP, heart failure with systolic dysfunction, acidosis, hypoxia/hypercapnia, where there's a decrease in phosphate slash, let me see, it's a PO, it says decrease in PO2 over increase in PCO2. Okay. Non-dihydropyridine calcium channel blockers also cause a decrease in stroke volume because, again, they're calcium channel blockers. So that makes sense, right? The things that increase contractility are things like catecholamine stimulation, increased calcium. What blocks it? What inhibits it? Beta blockers, right? Heart failure, acidosis, hypoxia, hypercapnia, and then calcium channel blockers. Non-dihydropyridine calcium channel blockers, which are like diltiazem and verapamil. What about preload? Preload, approximated by ventricular end diastolic volume, EDV, depends on venous tone and circulating blood volume, both of which affect venous return. So venous vasodilators like nitroglycerin decrease preload. Let me make sure that I'm not missing anything, because I feel like, yeah, here we go. That's what I was wondering. They had more to it than just what I was talking about before. Now let's talk about cardiac oxygen demand. They call it myocardial oxygen demand, I believe, in your book, so just look at that. So cardiac oxygen demand. Myocardial oxygen demand is increased by increase in contractility, an increase in afterload, which is proportional to arterial pressure, an increase in heart rate, and an increase in diameter of ventricle, which increases the wall tension. Coronary sinus contains most deoxygenated blood in the body. Wall tension follows Laplace's law. Wall tension equals pressure times radius. Wall stress equals pressure times radius divided by 2 and divided by wall thickness. And then we're going to talk about afterload now. Afterload approximated by mean arterial pressure. Increase in pressure causes an increase in wall tension per Laplace's law, which increases the afterload. Left ventricle compensates for increase in afterload by thickening hypertrophy in order to decrease wall stress. Arterial vasodilators, for example hydralazine, decrease afterload. ACE inhibitors and ARBs decrease both preload and afterload. Chronic hypertension, an increase in MAP, leads to a left ventricular hypertrophy. Now we're talking about cardiac output equations for stroke volume, ejection fraction, that kind of thing. I'm not sure they have it in here. Stroke volume, maybe they combined it or something, I'm not sure. We'll get to storyline curves in a bit, but not quite yet. I'm not sure where they're putting it, but I'll just read out the equations for you. Stroke volume. So equation and notes. Stroke volume equals end diastolic volume minus end systolic volume. Yeah, and the note is just saying what ESV stands for. Yes, ESV stands for end systolic volume. So basically, the end diastolic volume minus the end systolic volume, that difference is called the stroke volume, right? That makes sense because that's how much blood's being expelled. The ejection fraction. The ejection fraction equals stroke volume divided by end diastolic volume. That is also equal to end diastolic volume minus end systolic volume, all divided by end diastolic volume. And why is that? Because stroke volume has already been defined as being EDV minus ESV. So ejection fraction is an index of ventricular contractility, decreased in systolic heart failure. Usually normal in diastolic heart failure. Normal EF is about 50 to 70%. Cardiac output. See, and the whole point with that too, by the way, is that when we say ejection fraction, we're saying basically how much blood is being expelled from the ventricle during systole. And again, it's normally 50 to 70%. If it's way lower than that, probably something going on, Cardiac output. Cardiac output, or CO, equals, what does the Q stand for in this case? They're saying Q with a little dot on top. I'm like, sorry, I don't know what that means, unfortunately. I know it's been mentioned before. Flow rate, volumetric flow rate, okay. What do they define it on the next page rather than the first time they mentioned it? I'm not sure. Anyway, cardiac output is equal to the volumetric flow rate, which is equal to the stroke volume times the heart rate. Fick principle, cardiac output is equals the rate of O2 consumption, all divided by arterial O2 content minus venous O2 content. In early stages of exercise, cardiac output is maintained by an increase in heart rate and an increase in stroke volume. In later stages, cardiac output is maintained by an increase in heart rate only for stroke volume plateaus. Because stroke volume plateaus it can't get much farther than that. Diastole is shortened with increase in heart rate, that is to say ventricular tachycardia as an example, which leads to a decrease in diastolic filling time, which leads to a decrease in stroke volume, which leads to a decrease in cardiac output. Pulse pressure. Pulse pressure equals systolic blood pressure, SBP, minus diastolic blood pressure, DBP. Pulse pressure directly proportional to stroke volume and inversely proportional to arterial compliance. An increase in pulse pressure in aortic regurgitation, aortic stiffening, which is an isolated systolic hypertension in older adults, obstructive sleep apnea, which is an increase in sympathetic tone, high output state, that is to say, for example, anemia and hyperthyroidism, exercise, which is transient, decreases in the pulse pressure in aortic stenosis, as well as cardiogenic shock, cardiac tamponade, and advanced heart failure. Okay, what about the mean arterial pressure? Mean arterial pressure. I don't see it on here, but I'll describe it for you. Mean arterial pressure is equal to the cardiac output times the total peripheral resistance, which is TPR. So mean arterial pressure, which is MAP, at resting heart rate is equivalent to 2/3 of the diastolic blood pressure plus 1/3 of the systolic blood pressure, and then also is equivalent to the diastolic blood pressure plus 1/3 of the pulse pressure. So basically, MAP at normal heart rate is equal to 2/3 DBP plus 1/3 SBP, which is also equal to DBP plus 1/3 PP. Now let's talk about Starling curves finally. Starling curves, and you can see a normal one right there, and you can see one that's under the situation of exercise, and then one if you have somebody who has heart failure with digoxin trying to compensate for, and then heart failure without digoxin trying to help for it. Force of contraction is proportional to the end diastolic length of cardiac muscle fiber, which is preload. Increase in contractility with catecholamines, positive inotropes, for example, dobutamine and milrinone and digoxin. Decrease in contractility is caused with a loss of functional myocardium, for example, during an MI, or beta blockers acutely, or non-dihydropyridine calcium channel blockers, or heart failure. So basically, the things that would increase contractility, again, catecholamines, positive inotropes like dobutamine, milrinone, digoxin, okay, fair enough. The ones that decrease contractility, we kind of went over some of this stuff before already. Beta blockers, calcium channel blockers, heart attack, which can cause an issue with the myocardium actually functioning correctly, and of course, like heart failure. Now let's talk about the resistance pressure flow. Volumetric flow rate, which is Q with a little dot on top of it, volumetric flow rate is equivalent to the flow velocity, which is V, times cross-sectional area, which is A. Resistance, R, equals driving pressure change, which is delta P, divided by the flow rate. the volumetric flow rate. So basically resistance equals driving pressure divided by flow rate, which is also equal to 8, I'd like to say that's nu, 8 nu, which is viscosity. So 8 viscosity times length, all divided by pi times r to the power of 4. And it says here on the side for notes, let me continue reading this part. Total resistance of vessels in series is, RT, which is like the total resistance, equals R1 plus R2 plus R3 when they're in series. So when you have, let's say you have a pipe, it's going straight, it's a straight normal pipe. If the resistance in one place is 5 units, but it doesn't matter what the units are necessarily right now, and then the next area is 10 units, and the third place is 4 units or whatever, you just add them all together. What if they're in parallel? Well, then total resistance of vessels in parallel is going to be 1 divided by RT equals 1 divided by R plus 1 divided by 1 divided by R2 plus 1 divided by R3. So basically the total resistance is similar. It's still additive, but you treat everything as if it was a denominator for both sides of the equation, then you have to go flip it over at the end. And so actually, when you're in parallel, it actually very much helps reduce the amount of resistance you're going to experience. So let's go through the notes now, or the side portion. So it says change in P, which I would assume means change, which says change in P, delta P is driving pressure. So driving pressure equals the volumetric flow rate times resistance. This is analogous to Ohm's law for electrical currents, V equals I times R, that's true, where the volumetric flow rate is analogous to R to the power of 4, and R is analogous to 1 divided by 4 to the power of 4. 1 divided by R to the power of 4, yes. Capillaries have the high, and when I say analogous here, when I say Q versus R to the power of 4, there's an infinity sign with the last section cut off, which means it's not infinity, it's referring to something that's analogous as far as I'm aware. But please look that up if you want to. Capillaries have the highest total cross-sectional area and lowest flow velocity. Pressure gradient drives flow from high pressure to low pressure. Arterioles account for most of the total peripheral resistance. Veins provide most of the blood storage capacity. Viscosity depends mostly on hematocrit. Viscosity increases in hyperproteinemic states, for example in multiple myeloma, polycythemia. Viscosity decreases in anemia. Makes sense. So when we have higher viscosity, when you have lots of stuff in your blood, lots of proteins, lots of RBCs, when is it going to be low in viscosity? When you have low RBCs. Cardiac vascular curves. So cardiac output, venous return. And so you can see, for example, the different graphs right there. So you can have the cardiac output, venous return versus the right atrial pressure, or EDV. And the same thing you have for cardiac output / venous return for right atrial pressure, EDV. And it's the same thing for the third graph there. So you have 1, 2, 3, 4, 5, 6. And ABC. So read about them. Let's do this. Intersection of curves equals the operating point of the heart. That is to say, the venous return and cardiac output are equal, as circulatory system is a closed system. So graph effect examples. A for inotropy. Inotropy changes in contractility leading to an altered stroke volume, which leads to an altered cardiac output / venous return, VR, and a right atrial pressure, RAP. Examples include catecholamines, dobutamine, digoxin, and which are going to be positive. And then the heart failure, the things that inhibit it, that lower inotropy, are going to be heart failure with reduced ejection fraction, narcotic overdose, and sympathetic inhibition. So those will decrease inotropy. Inotropy just means contractility, basically. How strong is the contraction? Venous return. Changes in circulating volume lead to an altered RAP, which leads to an altered stroke volume, which leads to a change in cardiac output. And where RAP means right atrial pressure. So changes in circulating volume leads to altered right atrial pressure, which leads to altered stroke volume, which leads to a change in cardiac output. So 3, and remember there's a 3 on the diagram there. 3, fluid infusion. These are positive venous return. These increase fluid. This is going to increase venous return. Fluid infusion, sympathetic activity, and the arteriovenous shunt. Those will increase it. What will decrease it? Acute hemorrhage, spinal anesthesia. Those will decrease it, and then you can see that on the 4 for graph B, or diagram B. It's really a graph B at that point. And the third thing we're talking about, you can see in the third graph, graph C, total peripheral resistance. Changes in TPR cause an altered cardiac output. Changes in right atrial pressure is unpredictable. So what will increase the total peripheral resistance? Vasopressors. What will decrease it? Exercise and arteriovenous shunt. Again, you can see 5 vasopressors and then 6 the exercise/AV shunt right there on the third graph. Changes often occur in tandem and may be reinforcing. For example, exercise increases inotropy and decreases total peripheral resistance to maximize the cardiac output. Or they might be compensatory. For example, heart failure leads to a decrease in inotropy, but that leads to fluid retention to increase the preload to maintain the cardiac output. Very true. Okay. Okay, good. Okay. So, let's continue. We're on 292 right now, and we're going to wrap up at 238. So, we've already made a little bit of progress so far, but it's just it's a long chapter, you know. Yeah. We've gone through about a little bit less than, we went through maybe 9 pages or something like that. Perhaps maybe 8, I guess. But there's 45, so, you know, I think I've been developing an endurance for this, but unfortunately, it doesn't necessarily get that much easier, I guess you could say. Pressure volume loops, and also the time, obviously. The time doesn't necessarily change radically, you know. Anyway, pressure volume loops and cardiac cycle. And you can see that loop right there as well. The black loop represents normal cardiac physiology. The phases left ventricle. 1, isovolumetric contraction, which is a period between the mitral valve closing and the aortic valve opening, period of the highest O2 consumption. 2, systolic ejection, period between the aortic valve opening and closing. 3, isovolumetric relaxation, period between aortic valve closing and the mitral valve opening. And then 4, rapid filling, period just after mitral valve opening. And then 5, reduced filling, period just before mitral valve closing. And so just trying to give you perspective how, basically, let's say, hypothetically speaking, the left ventricle is now full, right? I'm going to undergo systole, and as a consequence, the ventricle is going to contract, and so it's going to start building up pressure. It initially closes off the mitral valve, right? The bicuspid valve, mitral valve, closes that immediately. That creates that systolic S1 sound. And then the pressure builds up so much that you can see the pressure increasing with 1 right there, that it eventually opens up the aortic valve, right? And that causes all this ejection of fluid from the ventricle into the aorta and therefore through the systemic circulation. And it continues squeezing and squeezing until eventually it's not able to go any further. It starts relaxing. And at that point, the aortic valve, because the pressure in the aorta is now higher than in the ventricle, it closes the aortic valve. And from there, the relaxation continues and continues. It's dropping in pressure, but the volume is not changing yet because the mitral valve is still closed, because still, even then, the actual pressure in the ventricle is still greater than that found in the atria, until the pressure drops so much in the ventricle that eventually the mitral valve opens up again and allows blood to flow into that left ventricle again. And that last third of blood volume found in the left ventricle is because of an actual atrial contraction. But the bulk of the blood that goes into the ventricle is a consequence of simply the fact that the pressure was lower for a period of time because of the relaxation. Anyway, heart sounds. S1, mitral and tricuspid valve closure, loudest at mitral area. Why is that happening, by the way? Because as I said before, that when you have the ventricles contract, they force the valves closed because now you have elevated pressure, but the aortic and pulmonic valves are not open quite yet. So basically, you're just building up pressure at that point because now both valves are closed. So that's S1, that's the beginning of systole. What about S2? Aortic and pulmonary valve closure, loudest at upper left sternal border. So that's basically S2 is the beginning of diastole. That's when the ventricles begin to relax, and as a consequence of that, the pressure in the aorta is higher than the ventricles. And so what happens is now the aortic valve and also the pulmonic valves close, and so that's the S2 sound. That's the beginning of diastole or the relaxation period. S3, in the early diastolic, and those are both normal sounds, by the way. When you hear bump, 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 those S1 and S2 sounds, those are normal sounds. What about S3 though? S3 in normal diastolic during rapid ventricular filling phase, best heard at the apex with patient in left lateral decubitus position, associated with increase in filling pressures. For example, the mitral regurgitation, aortic regurgitation, heart failure, and thyrotoxicosis, and is more common in dilated ventricles, but can be normal in children, young adults, athletes, and pregnancy. Turbulence caused by blood from left atria mixing with increased end systolic volume. So just bear that in mind that it can be normal for S3. S3 can be normal for certain people, but it also could be a pathological condition that it's making you aware of, essentially. So it could be one way or the other. What about S4? S4 in late diastole is an atrial kick. Turbulence caused by blood entering a stiffened left ventricle. Best heard at the apex with patient in left lateral decubitus position. High atrial pressure associated with the ventricular noncompliance, that is to say, hypertrophy. Considered abnormal if palpable, common in older adults. In that case, S4 is not considered physiological. It's not necessarily a healthy, normal sign in certain people. It's actually an indication of pathology necessarily. Almost always it's something going wrong, right? It's a stiff ventricle. S1 and S2, that's completely normal. S3, it might be there and that's okay. Maybe it's there and it's not okay. S4, there's something going wrong typically. So jugular venous pulse, JVP. And just be aware of that. It shows A, C, the X, the Y, all that stuff. That's actually going to be shown, I think, on that graph right there. Yeah, you see that purple line right there? It shows the A, the C, the X, the V, the Y. You can definitely see how it lines up with the S1, S2, S3, S4 sounds. You can see how it compares to the changes in pressure and stuff like that as well. Just be aware of that kind of, and also you can see the QRS complexes with the EKG as well, so you can kind of see how that lines up with each other. It's kind of, there's all just like different perspectives of looking at the same thing, basically. We're trying to understand how the heart works, and maybe the heart sounds or the EKG or the changes in volumes. These are different ways of looking at kind of the same phenomenon of the heart. So, jugular venous pulse, JVP. A wave, atrial contraction, prominent in the AV dissociation, canon A wave, and increase in right ventricle and diastolic pressure from any cause, absent in atrial fibrillation. C wave, which is kind of right there, mine's a little bit different, but it's similar concept, I suppose. C wave, right ventricular contraction, closed tricuspid valve bulging into the atrium. X descent, so that's the actual decline right there. X descent, atrial relaxation in downward displacement of closed tricuspid valve during rapid ventricular ejection phase, reduced or absent in tricuspid regurgitation, and right heart failure because the pressure gradients are reduced. V wave, which is that increase again, increase in right atrial pressure due to the increase in volume against closed tricuspid valve. What about the second descent, now the Y descent? Y descent, right atrial emptying into the right ventricle, prominent in constrictive pericarditis, absent in cardiac tamponade. So it would not happen in cardiac tamponade, but it would be exaggerated in pericarditis. In a constricted pericarditis, I should say. And we actually have another graph I have in my book. I'm not sure it's going to be in your book or not. It is not, but it's basically a similar graph as the one you just saw right here, but it shows different kinds of pathologies. And so I'll just list out the pathologies are. There's a normal heart with the ACXVY, okay. Then we have one that's with AFib. In an AFib, there's an absent A wave. So I would just look this up if I were you. Look up JVP, pressure tracings, diseases like normal AFib, tricuspid regurg, constrictive pericarditis, cardiac tamponade, just to see what they look like in terms of comparison. But for AFib, the A waves up front are absent. What about tricuspid regurgitation? Well, they have an absent X descent. There's still a Y descent, but there's no X descent. C and V are basically right next to each other. There's no distinction between the two. What about constricted pericarditis? Well, in that case, we said before, there's a prominent Y wave. What about cardiac tamponade? Well, the Y wave now is absent. Okay. Now we're talking about pressure volume loops and valvular disease. I'm not sure when we get to that point. I'll have to skip through here and there, not sure. So I'm not quite sure. My next page is on splitting, so I'll just leave it on splitting for now, and I'll start talking about the pressure volume loops and the valvular disease. So let's talk about aortic stenosis. So aortic stenosis, and I would look up, by the way, the pressure volume loops if I were you, just to understand how they work. You know what? I'm going to go show a picture of it as well, because here we go. This will help you understand how it looks. So the pressure volume loop page right there. I have my own little description right here for aortic stenosis and so forth. So if you think about that normal shape right there, and I think those little things right there hopefully are describing differences in terms of presentation. Let me see, afterload increase, left ventricular pressure, aortic pressure, what is it? Okay. Let me just describe it, okay. Aortic stenosis. And for aortic stenosis, what we can see is that the loop is shifted to the right, but it's not necessarily going past the general loop range of what's normally there, and it's also much taller, so because it reaches much higher pressures, right? So for aortic stenosis, you'll have a increased left ventricular pressure, an increase in end systolic volume, no change in the end diastolic volume though, if mild, and a decrease in stroke volume. Yeah, so the actual stroke volume will be smaller, but you'll have much higher pressures potentially, right? Left ventricular hypertrophy leads to a decrease in ventricular compliance, which leads to an increase in end diastolic pressure for a given end diastolic volume. What about aortic regurgitation? So aortic regurgitation is a little bit more rounded out, a little bit more egg-shaped in terms of the shape that we see here, but it's kind of shifted to the right. So it takes a lot of the same space as the original one did, but now there's a lot of more material, you could say a lot more shading right of the actual thing, which means that it takes up a lot more volume, even if the pressure doesn't necessarily get higher than it normally would be. So for aortic regurgitation, no true isovolumetric phase. There's an increase in end diastolic volume, right? You're talking before, there's more volume, higher stroke volume, loss of dichrotic notch. And you can say, whoa, there's a higher stroke volume, that's impressive. Yeah, I mean, it is more stroke volume, but it also, the reason is because the blood's trailing back into the ventricle from the aorta, and so if the whole purpose of having a high cardiac output is so that you can get a lot of blood to the body, well then it's not necessarily doing its job because that blood's backtracking into the left ventricle in the first place. So anyway, mitral stenosis. Mitral stenosis actually looks very similar in terms of how it compares to the normal pressure loop diagram, pressure volume loop diagram. The only difference is that it doesn't necessarily get as high of pressure. The pressure doesn't get as high. Or sorry, the volume doesn't get as high. The pressure stays the same. The volume is a little bit more limited in terms of it doesn't get as high as you would typically see for mitral stenosis. And that makes sense because you probably have less blood getting into the ventricle in the first place because it's being limited because of the stenosis of the stenosis of the mitral valve. So what do you see? Increase in left atrial pressure, decrease in end diastolic volume because of the impaired ventricular filling, decrease in end systolic volume, and decrease in systolic volume and stroke volume. And again, that's because the atrium are not as able to get blood into the left atria is not able to get blood into the left ventricle as efficiently because there's a stenosis present. And as a consequence, the ventricle doesn't get as nearly as voluminous as it normally would. And as a consequence of that, you have a lower stroke volume, lower EDV, lower ESV, all the above. Anyway, mitral regurgitation. So mitral regurgitation is, again, sort of like the aortic regurgitation. It's a little bit more rounded out, and it's a lot more voluminous, but the pressure doesn't get nearly as bad. The pressure in terms of its end systolic pressure is not nearly as high, but I think its end diastolic, its systolic pressure, I do think it's higher when it actually opens up the aortic valve. So the pressures are not as crazy different in terms of how things are, but the actual volumes that it will increase. When you have a lot of regurgitation, the volume can get much crazier, essentially. So let's start talking about mitral regurgitation. No true isovolumetric phase, decrease in the end systolic volume due to the decrease in resistance, and an increase in regurgitation into the left atria during systole, an increase in end diastolic volume due to the increase in left atrial volume / pressure from the regurgitation, which leads to an increase in ventricular filling, stroke volume, forward flow into the systemic circulation, plus backflow into the left atrium. Okay. Now we're going to be talking about the heart murmurs, and the splitting. Well, wait. We're going to be talking about splitting, but I'm going to take a short break. Okay, let's get back to it. The splitting. So splitting of S2. So talk about physiologic, or as your book calls it, normal splitting. Inspiration leads to a drop in the intrathoracic pressure, which leads to an increase in venous return, which leads to a increase in right ventricular filling, which leads to an increase in right ventricular stroke volume, which leads to an increase in the right ventricular ejection time. This leads to, this leads to a delayed closure of the pulmonic valve. Okay. So when you inspire, breathe in, right, it leads to eventually delayed closure of pulmonic valve, i.e. a delayed P2. As you can see there. Decrease in pulmonary impedance, which leads to an increase in capacity of the pulmonary circulation, also occurs during inspiration, which contributes to the delayed closure of pulmonic valve. E equals expiration, I equals inspiration. Wide splitting. Seen in conditions that delay the right ventricular emptying, that is to say, pulmonic stenosis and a right bundle branch block, causes delayed pulmonic sound, especially on inspiration, an exaggeration of normal splitting. So in this case, it's actually a bigger and it's a more abnormal delay. It's wider, and that could be caused by something like a right bundle branch block, right, as you can imagine, or a pulmonic stenosis. What about fixed splitting? What's going on with that? It's not physiologic, right? But it's a consistent gap between the two. Heard in ASD, which is atrial septal defect. Atrial septal defect leads to a left to right shunt, which leads to an increase in increase in right atrial and right ventricular volumes. That causes an increase in flow through the pulmonic valve, which causes a delayed pulmonic valve closure, which causes closure which is independent respiration. So it's not caused by respiration, it's just caused by this increased volume as a consequence of the ASD. That's fixed splitting. What about paradoxical splitting? Well, paradoxical splitting, you're going to have, it was heard in conditions that delay aortic valve closure, for example, aortic stenosis, left bundle branch block. Normal order of semilunar valve closure is reversed. In paradoxical splitting, P2 occurs before A2. On inspiration, P2 closes later and moves closer to A2, paradoxically eliminating the split. On expiration, the split can be heard opposite to physiologic splitting. So it's super weird. But what causes it? It's caused by aortic stenosis or left bundle branch block. So we're talking about before about bundle branch block. So if you have pulmonic stenosis or right bundle branch block, the splitting gets wider. It becomes more exaggerated. So the best way I can think of it is like this. You have a normal physiologic split that's heard on inspiration. Okay, fair enough. But the split gets wider when you have a right bundle branch block or pulmonic stenosis. I say stenosis of the pulmonic valve. But if you have paradoxical splitting, i.e. it's not the splitting is getting more exaggerated, but the splitting is actually inversing, is switching up, doing a reverse situation. What's that caused by? Aortic stenosis and left bundle branch block, i.e. the opposites of the things that cause wide splitting. So if wide splitting is caused by RBBB, right bundle branch block, and pulmonic stenosis, well, the thing that causes paradoxical splitting is going to be LBBB, left bundle branch block, right? And the aortic stenosis. So just keep that in mind. It's a good way to remember it, just for reference. Because if you know one, then you should know the other. If you know that wide splitting is caused by RBBB and PS, well, then you should know that paradoxical splitting is caused by the LBBB and AS. Fixed splitting, I don't know. You have an ASD, right? Okay. Now let's talk about the heart a little bit more, I suppose. Auscultation of the heart. So remember A, P, T, and M. Aortic, and this is when you actually when you go and you're taking, when you're actually working with a patient with a stethoscope, this is what you do. You go to A, P, T, and M. A is that area in the second intercostal space on the right sternal border. P is that space on the left sternal border, second intercostal space. Then T, you go below that, you go down to they say I've heard fourth and fifth intercostal spaces. I'm not sure what your book says here. Let me see. They say for T, they don't even specify. They imply it's the fourth intercostal space. So they imply it's the fourth intercostal space. And then in mitral, I've also heard fourth and fifth intercostal space, but they imply here that it's basically, that is fifth intercostal space. So you go down a space as far as they're concerned. And that's going to be, instead of on the sternal border, that's going to be on I believe the midclavicular line. So again, A, right sternal border, second intercostal space. P, pulmonic, second intercostal space, left sternal border. Tricuspid is going to be the fourth intercostal space, left sternal border, and then the mitral is going to be the fifth intercostal space, mid-clavicular line on the left side. And for aortic area, systolic murmur. So for aortic area, you can hear it, systolic murmur, aortic stenosis, flow murmur, for example, physiologic murmur, and aortic valve sclerosis. For pulmonic location, systolic ejection murmur, pulmonic stenosis, ASD, which is atrial septal defect, flow murmur. Mitral, or let me go tricuspid, hollow systolic murmur, hollow systolic for tricuspid regurgitation, and VSD, ventricular septal defect. Diastolic murmur, tricuspid stenosis. And then finally, the mitral area or apex region. That PMI is not that far away from that location as well. Mitral area, apex, systolic murmur, mitral regurgitation, mitral valve prolapse. The diastolic murmur would be mitral stenosis. The left sternal border, which is different from mitral, left sternal border, which you have right there as well, left sternal border, is systolic murmur, hypertrophic cardiomyopathy. If you have a diastolic murmur, then you have aortic regurgitation or pulmonic regurgitation. That's something I need to review because there are questions like that on some of these exams that you might have to look out for. Saying, oh, look, we put the stethoscope here and we heard this sound. It was pansystolic, it was hollow systolic, it was crescendo, decrescendo, whatever. What's going on? And you have to go figure that out. Or what to do. And the first thing of figuring out what to do is to figure out what it is in the first place. So maneuver and the effect. So mine says maneuver, cardiovascular changes, murmurs that increase with maneuver, and murmurs that decrease with maneuver. So let's talk about standing Valsalva, strain phase. This will cause a decrease in preload, which is going to be a decrease in the ventricular volume. This will exaggerate the mitral valve prolapse, which because of the decrease in left ventricular volume with earlier mid-systolic click, and it will exaggerate the HCM, which I forgot what that stands for. HCM, hypertrophic cardiomyopathy, I think is what that stands for. Okay. Let's go back. And murmurs that would be decreased with the standing Valsalva strain phase would be most murmurs, decreasing flow through the stenotic regurgitant valve. Okay. But it would exaggerate MVP and HCM. Passive leg raise. This will increase preload and increase the ventricular volume. What about squatting? Squatting will also increase preload and increase the afterload and increase the ventricular volume. Okay. Both of these, both the passive leg raise and squatting, will exaggerate most murmurs because it will increase the flow through the stenotic regurgitant valve. However, they decrease MVP and HCM because of the increase in the ventricular volume. So basically, the whole point of that is that most murmurs are exaggerated with passive leg raise and squatting, but specifically mitral valve prolapse and hypertrophic cardiomyopathy are the opposite, and they are exaggerated by the standing Valsalva maneuver. So it's a little bit kind of a contrast between the two. What about hand grip? Hand grip will significantly increase afterload, leading to an increase in reverse flow across the aortic valve, leading to left ventricular volume increase. This will exaggerate most other left-sided murmurs like aortic regurg, mitral regurg, and VSD, which is ventricular septal defect. Okay, but it will decrease or tone down the AS. What is that? Aortic stenosis? Yes, aortic stenosis, because of a decrease in transaortic valve pressure gradient. It also will decrease the hypertrophic cardiomyopathy because of the increase in the ventricular volume. The inspiration, this will increase venous return to right heart, and it will also decrease the venous return to left heart. This will exaggerate most right-sided murmurs, which increases with inspiration. But this will decrease most left-sided murmurs, which increase with expiration. Okay, now we're going to go over to the next section on heart murmurs. Okay, aortic stenosis. So we're talking about heart murmurs, aortic stenosis. So we're talking about auscultation, clinical associations, and notes. So aortic stenosis, and you can see that S1, S2. There's a little bit of rumbling between the two. Crescendo, decrescendo, ejection murmur. Loudest at heart base, radiates to the carotids. Soft, S2 plus or minus the ejection click, pulses parvus et tardus, weak pulses of delayed peak. Clinical associations, age-related calcification, greater than 60 years of age, and early onset calcifications of bicuspid aortic valve at 50 to 60 years old. Notes it can lead to syncope, angina, and dyspnea on exertion. SAD. Left ventricular pressure left ventricular pressure is greater than the aortic pressure during systole. Well, what about mitral or tricuspid regurgitation? Holosystolic, high-pitched blowing murmur. Mitral regurgitation is loudest at the apex and radiates down towards the axilla. The tricuspid regurgitation is loudest at the tricuspid area. So mitral regurgitation, often due to ischemic heart disease, post-MI, mitral valve prolapse, left ventricular dilation, or rheumatic fever. While the tricuspid regurgitation is often due to right ventricular dilation and may be secondary to permanent pacemaker placement. Mitral regurgitation or tricuspid regurgitation can be related to infective endocarditis. What about mitral valve prolapse? Late crescendo murmur with mid-systolic click, MC, that occurs after carotid pulse, best heard over apex, loudest just before S2. Usually benign, but can predispose to infective endocarditis. Can be caused by rheumatic fever, chordae rupture, mitral annular disjunction, or myxomatous degeneration, primary or secondary to connective tissue disease. Mitral, MC, mid-systolic click is due to sudden tensing of the chordae tendineae as mitral leaflets prolapse into the left atria. Chordae cause crescendo of click. What about a VSD, a ventricular septal defect? Holosystolic, harsh sounding, murmur, loud at tricuspid area. It's congenital, and larger VSDs have lower intensity murmur than smaller VSDs. And I also want to point out to you right now that when you have a regurgitation, or a VSD, I guess in this case as well, let me make sure I'm not saying this incorrect. No, it's not so clear. For this, it doesn't show it as being as clear. Because it's going to say like a VSD and that's correct. That's correct. When you have mitral valve regurgitation or tricuspid valve regurgitation or a VSD, those are all going to be holosystolic. And that makes sense because you will have action going on those locations during the entirety of systole. You know, if your ventricle is contracting, you're going to be having blood flow through that VSD or through the mitral and tricuspid valves because, again, they're experiencing regurgitation the entire time of systole. So it's holosystolic, it's pansystolic. However, if you have aortic stenosis, it's going to be, a crescendo decrescendo because you don't necessarily open up the aorta immediately. It opens up during some point in systole. So as a consequence of that, you have more of this weird shaped thing going on with the aorta. Essentially, it's kind of an imperfect way to describe it, but it's kind of how it works. Same thing true for mitral stenosis. Mitral stenosis is a similar situation where it's not opening up immediately. But I'll go into more of it. Diastolic. Aortic regurgitation. Early diastolic decrescendo, high-pitched blowing murmur, best heard at the base, aortic dilation, or left sternal border, valvular disease. Causes include bare, bicuspid aortic valve, endocarditis, aortic root dilation, and rheumatic fever. Wide pulse pressure, pistol shot femoral pulse, pulsing nail bed. Hyperdynamic pulse and head bobbing when severe and chronic can progress to left heart failure. So in that case, the aortic regurgitation is not necessarily going through the entirety of diastole in a consistent pattern. It's high initially during the beginning of diastole, but then it kind of like mellows out later on. It's early diastolic, decrescendo presentation. blowing murmur. What about mitral stenosis? Follows opening snap, OS, delayed rumbling, mid to late murmur, leading to a decreased interval between S2 and OS correlates with an increase in severity. So the bigger when the interval between the two is smaller, that correlates with a greater severity between the S2 and the O2. Late and a highly specific sequelae of rheumatic fever. Chronic MS can result in LA dilation and pulmonary congestion, atrial fibrillation, Ortner syndrome, hemoptysis, and right heart failure. I think they mean chronic multiple sclerosis for MS. OS, again, that OS means opening snap. Opening snap due to abrupt halt in leaflet motion and diastole after rapid opening due to the fusion at leaflet tips. Left atria is much greater than left ventricular pressure during diastole. For continuous, and that's kind of a weird thing to think about, it's much higher, but it makes sense because, again, you have mitral stenosis, so it's building up all that pressure because it can't get it out. Patent ductus arteriosus. This is a continuous machine-like murmur, best heard at left infraclavicular area, loudest at S2. Often due to congenital rubella or prematurity. You need a patent for that machine. Okay, so the way you might remember is that for machines, you need a patent. So if you have a PDA, you have a machine-like murmur. It's a very weird one, very uncharacteristic of everything else. It's its own unique thing. Myocardial action potential. And your book says also occurs in bundle of His and Purkinje fibers. Okay. But myocardial action potential. Oh, my book says actually occurs in all cardiac myocytes except those in the SA and AV nodes, which I guess you would mean, i.e., Purkinje fibers and bundle of His. So, phase 0, rapid upstroke and depolarization. Fast voltage-gated sodium channels open. So that's phase 0. And you can look at the phase 0 right here as well. If you can see the diagram right there with the that massive shoot up, that spike right there initially, that's the phase 0. Phase 0, rapid upstroke and depolarization. Fast voltage-gated sodium channels open. Phase 1, initial depolarization. Inactivation of voltage-gated sodium channels, transient outward voltage-gated potassium channels begin to open. Phase 2, plateau, okay, sure. Calcium channel influx through the voltage-gated calcium channel balances the potassium efflux. Calcium influx triggers a calcium release from the sarcoplasmic reticulum and myocyte contraction, excitation-contraction coupling. Phase 3, rapid repolarization, potassium efflux due to opening of the voltage-gated slow-delayed rectifier potassium channels and closure of the voltage-gated calcium channels. Phase 4, resting potential. High potassium permeability through potassium channels. In contrast to skeletal muscle, cardiac muscle has the following characteristics. Action potential has a plateau due to the calcium influx and opposing potassium efflux. Contraction requires calcium influx from ECF due to induce a calcium release from the sarcoplasmic reticulum, calcium-induced calcium release. Myocytes conduct excitation throughout the heart via gap junctions. And so all those things are in contrast to the skeletal muscle. And the best way I can phrase it, you can see it right there. The best way I can think of it is like this. See phase 0? So you have this massive, that's where the kind of QRS complex is going, I guess. But it's basically that massive upstroke, that massive stage of depolarization. And then your body's going to try to correct initially on, where you're going to have some, how you say, where is it? Some potassium channels open up. And you're going to try to repolarize. But your body says, no, we need to go kind of bring this out as long as possible. And so you start having some, at the same time, calcium channels going in the opposite direction. and they're going to kind of stave off the repolarization for a time until eventually they close, and they eventually allow the potassium channels to do their job and then repolarize. So phase 1 and phase 3 are basically the same thing. It's just that phase 2 has this period of calcium channels that help prevent the inevitable repolarization stage. And when repolarization is done, well, then you have phase 4. Pacemaker action potential. Key differences from the ventricular action potential include phase 4, which is a slow spontaneous diastolic depolarization due to IF, funny current. HCN channels are responsible for a slow mixed sodium-potassium inward current, different from the INA, which is I sodium, in phase 0 of the ventricular action potential. Accounts for the automaticity of the SA and AV nodes. The slope of the phase 4 in the SA node determines the heart rate. The acetylcholine adenosine decrease in the rate of diastolic depolarization and the decrease in heart rate, while the catecholamines increase depolarization and increase in heart rate. Sympathetic stimulation increases the chance of the HCN channels are open and thus increase the heart rate. Okay, good. I'm going to make sure I'm not missing anything. So that's phase 4. So phase 4 is that whole process of kind of like maintaining this low charge, essentially. But it builds up, there's a build-up going on in phase 4 until eventually you reach a certain point at around -40. And then you initiate phase 0. Phase 0, upstroke, opening of the voltage-gated calcium channels. Fast voltage-gated sodium channels are permanently inactivated due to the less negative resting potential of these cells, leading to a slow conduction velocity used by AV nodes to prolong transmission from atria to the ventricles. So these are where the L-type calcium channels are happening right here at phase 0. And so it's very similar to the phase 0 that you see before we were talking about in the cardiac myocytes, except this one's a little bit more, it's not as sharp, I guess you could say. It's still a radical increase, but the borders, it looks a little bit differently. Let's phrase it like that. And finally, phase 3, you say, well, what about phase 1 and 2? Not a thing. There's no point where the thing says, oh, let's do a phase 1, and then it cuts it midway with the calcium channels, and it causes it to stave off. No, there's a phase 0, where there's a depolarization, and then it immediately skips 1 and 2, and goes directly back into repolarization for phase 3. And then it goes back into phase 4, which is sort of this baseline period. So 1 and 2, that period of immediate initial repolarization followed by a period of staving off, those with a plateau, those do not exist with this pacemaker action potential. They skip those 2 phases. They only have phase 0, phase 3, and phase 4. So phase 3, repolarization, inactivation of the calcium channels, and increase in activation of potassium channels leading to an increase in potassium efflux. Okay. So bear that in mind. There's definitely similarities between the two, but they're not the same. And we'll be going on to the electrocardiogram. We're on page 298. We're trying to get to 328 today. It'll probably take a while, but I will go take a short break. So if you're watching this and this is now a recording and you're watching and I'm in the past, I get that at that point, I'll be taking a short break, so just skip forward if you have to. Okay, we're back. So let's continue on with the electrocardiogram, also called the ECG or the EKG. Conduction pathway, SA node to the atria. Let me just go show you the picture right here so you can see it as well. Just look at the heart. Okay, I want to make sure that you can see the whole thing. Let's go down a little bit. Here, see if you can see it now. Oh, there we go. Let me just go up a little bit. Okay. Electrocardiogram conduction pathway. SA node goes to atria, which goes to the AV node, which goes to the bundle of His, which goes to the right bundle branch, and the left bundle branch, which divides into left anterior and posterior fascicles, which leads to the Purkinje fibers, which then goes to the ventricles. The left bundle branch divides into the left anterior and posterior fascicles. SA node, located in the upper crista terminalis near the SVC, superior vena cava, typically serves as a dominant pacemaker for the heart rate, with slow phase of upstroke. AV node, located in the interatrial septum near the coronary sinus opening, blood supply via the PDA. That's the via PDA. 100 millisecond delay allows time for ventricular filling. Pacemaker rates greatest in SA, then atria, then the AV, then the bundle of His / Purkinje / ventricles. Speed of conduction is highest in the His Purkinje fibers, followed by the atria, followed by ventricles, followed by AV node. He parks at Ventura Avenue. Just remember, though, that the SA node has the highest pacemaker rate, and the atria and AV and so forth kind of trail behind. But the actual fastest stuff that allows for coordination of the actual impulse is the His Purkinje fibers. His Purkinje fibers exist in order for the body, for the heart, to rapidly send the signal across the body. Rapidly send the signal across the entire heart, so it's kind of a coordinated movement. Make sense? And so even though the His Purkinje fibers could theoretically send a signal if nothing else is working, it's really there to just transmit the impulse. Again, initially coming from the SA node typically. And they might say, well, why is it relevant if the SA node is the normal side of the pacemaker? Why do we care about the hypothetical pacemaker rates of other places? Well, what happens if the SA node is not working? What happens is that something else has to go pick up the pace and start becoming the new pacemaker, which is an interesting concept, right? The body will actually use a new part of the tissue as a new pacemaker, including things like the AV, including the atria, whatever, that kind of thing. So, but ideally it is but in those cases where let's say the SA node is not working, you will have a lower heart rate because those other locations really can't sustain as high of a heart rate as the SA node typically would. So bear that in mind as well. And there's all sorts of weird things on the EKG you can find if you have situations where there are heart rates or let's say depolarizations originating from somewhere other than the SA node. Particularly if it's ventricular. Ventricular depolarizations look very strange on an EKG. Anyway, let me go back down. P wave, atrial depolarization. PR interval, time for start of atria depolarization to start ventricular depolarization, normally about 120 to 200 milliseconds. QRS complex, ventricular depolarization, normally about less than 100 to equal to or less than 100 milliseconds. QT interval, ventricular depolarization, contraction, repolarization. T wave, ventricular repolarization, inversion may indicate ischemia or recent MI. J point, junction between the end of QRS complex and the start of the ST segment. ST segment, isoelectric ventricles depolarized. U wave, prominent in hypokalemia, think hypukalemia, bradycardia. Okay, sure. And so you can see that EKG, you can see the QRS complex, P wave QRS complex, the QT interval, T wave, all that jazz. You see here the atrial depolarization, as you can see, the ventricular depolarization, the ventricular repolarization as emblematic of the P wave, the QRS complex, and the T wave, respectively. P wave is related to the atrial depolarization, QRS complex related to the ventricular depolarization, and then the T wave related to the ventricular repolarization. You might ask yourself, okay, wait a minute. So we have the repolarization for the ventricular region by the T wave, but we don't have a wave related to the atrial repolarization or atrial repolarization. Why is that? Well, it's normally covered up by the QRS complex, and even if it was not present, even let's say for example you didn't have a QRS complex there, it's so small. Otherwise, it'd be indistinguishable, but it's so tiny that it'd be hard to see, and then it's normally covered up by the QRS complex anyway. So it's basically not relevant. I'm actually going to be talking about A and P first, so I don't know where that comes in, but let's see if we can find it. Atrial natriuretic peptide. Because it looks like they start talking about pathology, basically. Well, technically no. They're saying no, Torsades is physiology. Well, I mean, it's really a pathological thing, but whatever. Atrial natriuretic peptide. Released from the atrial myocytes in response to an increase in blood volume and an atrial pressure. Acts via cyclic GMP, causes vasodilation and a decrease in sodium reabsorption at the renal collecting tubule. Dilates afferent renal arterioles and constricts efferent arterioles, promoting diuresis and contributing to aldosterone escape mechanism. And a good way to think about how ANP and BNP works is kind of like they're the opposite of aldosterone in terms of their actual effect. BNP and ANP have the opposite effects of aldosterone. They they don't want to have sodium reabsorbed, and they also want to have some vasodilation, essentially. Aldosterone wants to have the opposite happen. The RAS activation pathway wants to have a higher blood pressure. It wants to have more sodium, it wants to have more water, that kind of thing. So B-type brain natriuretic peptide, released from the ventricular myocytes in response to the increase in tension. Similar physiologic action to ANP with longer half-life. BNP, blood test used for diagnosing heart failure, very good negative predictive value. And so ANP is in the atriomyocytes. BNP was originally found in the brain for some reason, but it is found in the ventricles as well, and that's where it's relevant in our context. So baroreceptors and chemoreceptors. Baroreceptors, chemoreceptors, receptors. Aortic arch transmits via the vagus nerve to nucleus tractus solitarius in medulla, responds to the changes in BEP, in blood pressure. Carotid sinus, dilated region superior to bifurcation of carotid arteries, transmits via the glossopharyngeal nerve to nucleus tractus solitarius in medulla, responds to the changes in blood pressure. Chemoreceptors. Peripheral carotid and aortic bodies are stimulated by the PCO2, by the increase in PCO2, a decrease in pH of blood, and a decrease in PO2, less than 60 mmHg. Central are stimulated by changes in pH and PCO2 of brain interstitial fluid, which in turn are influenced by arterial CO2, as the hydrogen ions cannot cross the blood-brain barrier, do not respond to PO2. Central chemoreceptors become less sensitive with chronically increased PCO2, for example in COPD, and leading to an increase in dependence on peripheral chemoreceptors to detect decrease in O2 to drive respiration. What about baroreceptors? Hypotension, decrease in arterial pressure, which leads to a decrease in stretch, which leads to a decrease in afferent baroreceptor firing. This leads to an increase in efferent sympathetic firing and a decrease in efferent parasympathetic stimulation, which leads to vasoconstriction, increase in heart rate, and increased contractility, and increase in blood pressure. Important in the response to hypovolemic shock. Carotid sinus hypersensitivity, elicited by carotid massage, shaving, tight necktie or shirt collar, leading to an increase in carotid sinus pressure, which leads to an increase in afferent baroreceptor firing. This leads to an increase in AV node refractory period, which causes a decrease in heart rate, which causes a decrease in cardiac output. Also leads to peripheral vasodilation. It can cause presyncope/syncope, exaggerated and underlying atherosclerosis, prior neck injury, and older age. Component of Cushing reflex triad of hypertension, bradycardia, component of Cushing reflex, which is a triad of hypertension, bradycardia, and respiratory depression. Increase in intracranial pressure constricts arterioles, leading to a cerebral ischemia, which leads to an increase in PCO2 and a decrease in pH. This leads to a central reflex sympathetic, increase in perfusion pressure, hypertension. This causes an increase in stretch. This causes an increase in peripheral stretch baroreceptor, induced bradycardia. And you can see the graph right there showing the relationship between them. You have the vagus nerve, the glossopharyngeal nerve, the carotid sinus baroreceptor, and the carotid body chemoreceptor. Good way to remember this is that the carotid body is the baroreceptor, and the carotid sinus is the the carotid body is the chemoreceptor, and the carotid sinus is the baroreceptor. So think about the body is the chemoreceptor, so the B and the C, but the carotid sinus is the baroreceptor, so it's this. I think of it as a C, even though it's not. But it's a sinus and the baroreceptor, so S and B, or I would say C and B, even though it's an S, but SB versus the body and the chemoreceptor BC. So basically, the B's are not together, and the C or S is not together. They're separated, basically. So when you have the sinus, it's a baroreceptor. When you have the body, it's a chemoreceptor. Normal resting cardiac pressures. Pulmonary capillary wedge pressure, or PCWP, in MMHG is a good approximation of left atrial pressure, except in mitral stenosis when PCWP is greater than left ventricle pressure. Except in mitral stenosis when the PCWP is greater than left ventricular and diastolic pressure. PCWP is measured with pulmonary artery catheter, which is called Swan-Ganz catheter. Okay. So normally it's about the same. It's similar. It's a good approximation, but it will be PCWP will be much higher than left ventricular and diastolic pressure if you have mitral stenosis, which makes sense because mitral stenosis is associated with, it's hard for the blood to get out of the left ventricle. Out of the left atrium. And therefore you have a low left ventricular pressure when you have mitral stenosis, which is why the PCWP would still be much higher than that, within left ventricular and diastolic pressure. Okay. Autoregulation. How blood flow to an organ remains constant over a wide range of perfusion pressures. Organ, factors determining autoregulation. Lungs. Hypoxia causes vasoconstriction. Heart. Local metabolites vasodilatory like NO, CO2, and a decrease in oxygen. Brain. Local metabolites vasodilatory like CO2, which is going to impact the pH. Kidneys. Myogenic, stretch-dependent response of afferent arterial and tubuloglomerular feedback. Skeletal muscle. Local metabolites during exercise vasodilatory. Chalk, so CO2, hydrogen ions, adenosine, lactate, and potassium. At rest, it's the sympathetic tone and arteries. What about skin? Sympathetic vasoconstriction, most important mechanism for temperature control. And there's a little note right here that says, the pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction so that only well-ventilated areas are perfused. In other organs, hypoxia causes vasodilation. And that's pretty obvious because the lungs are trying to get oxygen so they can have oxygenated blood, while everything else is the opposite, where they're trying to get oxygen from the blood. So it's the opposite situations. They have opposite rules. The lungs want to get as much oxygen as possible, so they have to go say, these areas have low perfusion. Then we have to have basically send the blood to some other area that's more efficient in bringing up oxygen into the blood. Well, for the body, when it has low oxygen environment, it says we need to have more blood into this area to help supply it with proper oxygen. Capillary fluid exchange. Starling forces determine fluid movement through the capillary walls. PC equals capillary hydrostatic pressure, pushes fluid out of the capillary. PI is equivalent or equal to interstitial hydrostatic pressure, pushes fluid into the capillary. Pi C, plasma oncotic pressure, pulls fluid into the capillary. And then pi I, interstitial fluid oncotic pressure, pulls fluid out of the capillary. JV equals net fluid flow, which equals KF times, in all parentheses, or all brackets, parentheses, PC minus PI, parentheses, minus, I think that's a sigma? Sigma times pi C minus pi I, parentheses, bracket. KF equals capillary permeability to fluid. Sigma equals reflection coefficient, measure of capillary permeability to protein. Edema, excess fluid outflow into the interstitium commonly caused by increased capillary hydrostatic pressure, which causes an increase in PC, that is to say, for example, heart failure. Increase in capillary permeability, increasing the KF, for example, in toxins, infections, and burns. An increase in interstitial fluid oncotic pressure, which will cause an increase in pi I, for example, lymphatic blockage, or a decrease in plasma proteins, for example, a decrease in pi C, for example, nephrotic syndrome, liver failure, and protein malnutrition. And I have a little graph as well, a little diagram, I should say. And your book has a little diagram as well. But the best way to remember it is this. If you want to have, the things that can cause edema are this. When you have edema, what it means is that you have a high hydrostatic pressure in the blood or a low colloid osmotic pressure in the blood. Because the colloid osmotic pressure in the blood is good because it pulls things. Let's say you have albumin in the blood, that'll pull fluid towards it. But when you have a lot of pressure, hydrostatic pressure, lots of water, whatever, that's going to push the fluid out of the blood, out of the vasculature and into the actual interstitial tissue space. And so you don't want that. So you want to have in the blood itself low hydrostatic pressure, high colloid osmotic pressure. So you want to have a low blood volume or a low blood pressure, and you want to have a high albumin level or a high oncotic pressure in the blood. Now, and the opposite is the case for the interstitium. In the interstitium, you want to have, limited oncotic pressure, less of a pull factor, and comparatively high hydrostatic pressure. So it's not too crazy of a difference. So the biggest factors, of course, is when you have hypertension, when you have nephrotic syndrome, which causes you to lose your albumin, when you have high capillary permeability, which allows the blood to freely go back and forth, and therefore you're going to have fluid starting pulling up in the interstitium. Or when you have, what else do you have? Yeah, when you have interstitial fluid oncotic pressure for some reason, so like lymphatic blockage, the lymph nodes are backing up because they can't get through for some reason. Therefore, you have a high oncotic pressure potentially in that area for some reason. Okay, and that brings us over to the pathology section. Now, we've been talking about pathology a lot already, but now we're officially in the pathology section going disease by disease. And I'll be taking a brief break as well, so you might have to skip ahead for this one as well. On second thought, I was thinking about it. So I'm already about close to 2 hours in right now, and we're on 302, which means we have about 36 pages to do, and we've gone through. Let's see, we started on 283, and we're in 302. So we went through maybe like 19-ish pages, 18-ish pages, basically. It's going to be, I've been here for 2 hours, so you get about 10 pages done every hour or so. And so we have another 35 pages. Another 35 pages. I mean, we're going to have basically another 3.5 hours. I don't know if I have the endurance to go through 5.5 hours today, and I don't know if I wanted to spend the next 3.5 hours given how much there's other things I want to do today, per se. So we're going to stop right here and get onto the pathology section maybe tomorrow or some other time. So if you stuck around for this time, hopefully it was of good use to you, and thank you for watching.